Hi there, I'm Tony Lee, and this is Hot Flasher, your daily menopause podcast that serves up fresh news, research, and wellness tips. I've built a daily news pipeline to find the latest on women's health and menopause research. Allow me to introduce my co-host Nikki, who handles the headlines. Take it away, Nikki.
Thanks, Tony. We've got some genuinely interesting research to dig into today. Let's start with a study that reframes something a lot of you are probably dealing with, and not necessarily thinking about this way. The paper is titled Causal Effects of Circulating Inflammatory Proteins on Postmenopausal Atrophic Vaginitis in European Populations, published in 2026. It uses a method called Mendelian randomization, and I want to actually explain that because it matters for understanding why this study is more compelling than the usual observational work in this space. Atrophic vaginitis, more accurately called GSM, genitourinary syndrome of menopause, gets framed almost entirely as a hormone story. Estrogen drops, tissues thin, the vaginal environment changes, discomfort follows. That's true as far as it goes. But this study asked a different question. Are circulating inflammatory proteins causally involved in that process, not just correlated with it? Mendelian randomization works like this. You take genetic variants that are known to influence a specific exposure. In this case, levels of certain inflammatory proteins in the blood. And you use those genetic variants as a proxy because your genes are assigned at conception and don't change based on your lifestyle or other health conditions. This method gives you a much cleaner read on causality than a study that just measures inflammation levels and GSM symptoms at the same time. You're not perfectly eliminating confounding, but you're significantly reducing it. The tool your doctor might pull up on something like open evidence would treat this kind of evidence differently than a small observational trial, and for good reason. What the researchers found is that several specific inflammatory proteins appear to have genuine causal effects on developing postmenopausal atrophic vaginitis. They validated this with transcriptomic analysis, looking at gene expression patterns in tissue, which added another layer of support. Why does this matter clinically? Because if inflammation isn't just a downstream result of GSM, but an actual driver, that opens up new targets. Local estrogen therapy remains the evidence-based gold standard for treating GSM, and this study doesn't displace that. But it raises the real possibility that for women who can't use or don't want to use estrogen, and that's a significant group, including many women with hormone-sensitive breast cancer histories, inflammation targeting approaches might be worth investigating seriously. That's a pathway that hasn't been well developed yet, and this gives it a biological rationale. One thing worth noting, the study was conducted in European populations. That's a real limitation. Inflammatory protein profiles and genetic variants can differ across ancestries, and GSM affects women worldwide. The findings need replication in more diverse cohorts before you can generalize broadly. But the methodology here is solid, and the transcriptomic validation is not nothing. This is the kind of paper that should be generating follow-up research. GSM is estimated to affect somewhere between 50 and 70% of postmenopausal women, and it's still massively underreported, partly because women don't bring it up, and partly because clinicians don't ask. The fact that we might be working with an incomplete biological model of what's causing it is worth sitting with. Cholesterol is another one of those things that gets under-discussed in the context of menopause. Specifically, there's a 2026 cross-sectional study out of Korea, Lee D.Y. and colleagues, looking at sex-specific prevalence and associated factors of dyslipidemia in Korean adults, and the menopause signal in it is stark. Dyslipidemia means abnormal lipid levels, high LDL, low HDL, high triglycerides, or some combination. It's a major cardiovascular risk factor, and the reason this study is relevant here is what it shows about women relative to men across the lifespan. Before menopause, women tend to have more favourable cholesterol profiles than men of the same age. Estrogen is doing protective work on the lipid panel, raising HDL, keeping LDL in check. After menopause, that changes. The study found that postmenopausal women showed significantly higher rates of dyslipidemia compared to premenopausal women, and the gap between women's risk and men's risk narrowed considerably. In some lipid parameters, postmenopausal women's risk exceeded age-matched men. Cross-sectional studies have limits. This is a snapshot in time, not a longitudinal follow-up, so you can't watch individual women's cholesterol shift across the menopause transition directly. But the pattern is consistent with what we already know mechanistically, and the sample size in a Korean national health dataset is large enough to take the association seriously. The practical implication is one that still doesn't seem to land consistently in primary care. Menopause is a cardiovascular event horizon. It's not just about symptoms. It's not just about bones. The lipid panel of a 55-year-old postmenopausal woman should be looked at differently than the same numbers in a 40-year-old premenopausal woman. And the risk trajectory going forward is meaningfully different. Cardiovascular disease is the leading cause of death in women, and the postmenopause years are when that risk starts climbing fast. If you haven't had a full lipid panel done since entering perimenopause or menopause, that's worth flagging with your doctor. Not because this study alone tells you what to do, it doesn't, but because the evidence base on this is consistent and the clinical response often lags behind it. The third piece today is a case report from PubMed. A 48-year-old woman with shortness of breath and a recent diagnosis of breast cancer, BEN-GSM, published in March 2026. Case reports are a different animal from randomized trials or large population studies. They're meant to teach through a single clinical story to surface something that practitioners might miss. I'm not going to speculate on what the specific diagnosis was in this case. I don't have the full clinical details, but the scenario the title sets up is a well-documented trap in medicine. A 48-year-old woman, recent breast cancer diagnosis, new symptom, shortness of breath. The cognitive pull in that clinical moment is extremely strong toward anchoring on the known diagnosis. Breast cancer spreads to the lungs. It causes pleural effusion. Chemotherapy causes cardiac effects. The symptom fits, so you look there. The risk is that something else, a pulmonary embolism, a new primary cardiac condition, something entirely unrelated, gets missed or delayed because the framing of cancer patient with a symptom narrows the diagnostic aperture. This is called anchoring bias, and it's one of the most well-documented sources of diagnostic error in medicine. Patients with serious known diagnoses are not immune to developing unrelated conditions, and midlife women in general already deal with a version of this problem where symptoms get attributed to menopause or anxiety rather than investigated on their own terms. A 48-year-old is squarely in perimenopausal territory. She may have been dealing with hot flashes, mood changes, disrupted sleep, all the things that come with that transition, on top of a cancer diagnosis. The clinical picture for a woman in that age window is genuinely complex. Case reports like this one exist precisely because complexity gets flattened in the 5-minute appointment. And sometimes the cost of that is real. The takeaway isn't your doctors are failing you. It's more specific than that. Shortness of breath in a midlife woman, regardless of what else is going on in her medical history, deserves its own workup. Symptoms don't automatically belong to the most prominent diagnosis on the chart.
Thanks for listening to Hot Flasher. We're back tomorrow with more, so don't forget to subscribe. See you tomorrow.